Hello and welcome to Makota Ask the Expert channel, where we delve into the inspiring story, expert advice, and latest innovation in healthcare. I'm your host, Carrie. We are honored to have our esteemed medical professionals from Makota Medical Center who are at the forefront of patient care, sharing with us their expertise, insight, and advice.
So migraine is considered a chronic pain, right?
Yes. This we call it pain of the non-specific origin from the nerve. We call it headache. There are many types of headache. We have cluster headache. We have 𝐄𝐱𝐩𝐞𝐫𝐭𝐬 headache, which is related to the cervical spine. We have chronic migraine, which does not respond to the normal intervention like conservative management with drugs. So this is a chronic pain. We can intervene as well with some block on the certain nerve which supplies to the area of pain generated to the migraine.
So meaning to say that actually many at times, right?
Yeah.
Migraine does affect a lot of patients and it does impact their quality of life. Even like not able to work, not able to study, example, with loss of stress. So do you mean that migraine can be treatable?
Because there is some criteria to intervene. Not all migraine we do intervention. Usually suffice with the common drugs medication for anti-migraine that usually we have, and also we prevent the aura, something that provoke the migraine. So all this can be done first before we do intervention. But if the pain due to migraine is severe and no longer respond to the current management, then we offer the intervention because it helps in terms of reducing the pain caused by the nerve, for example, impingement at the back of the head. So the nerve which is applied to the C1 and C2 cervical level, that actually sometimes reduce pain after we intervene with block there under ultrasound guided. So that is an example.
I think nowadays got a lot of people will have this type of pain because we are always like moving down our head for phone or whatever, right?
Yeah, that one is more of pain headache due to sometimes because of the we call it refractive error. When you strain yourself and then there is increase in the power for the reading, that cause pain as well. There is a throbbing pain at the back of the eyes. That one different. We don't intervene that one. We have to do corrective error by changing our spectacles. No need intervention. But that's why we have to identify where the origin of the pain generator. That means if patient got headache, and example cluster headache, very severe pain throbbing at the back of the head, at the back of the eyes. It's like something punching the eyes. So when we intervene with, for example, ultrasound guided greater occipital nerve block at the back, so it improve. But there is a criteria to diagnose cluster headache as well. But it must be follow the diagnostic criteria for that, and from there we can intervene.
Okay. So that means that actually pain, right, is very subjective from people to people. So how do you actually classify how pain am I, right? As a doctor, when you ask a patient, right, before you deciding on whether should I still consider a medication or should I consider an interventional with some procedural done for the patient?
Yes, thank you for that question. So how do I assess the severity of pain? So in clinical setting, we do certain assessment to the patient to grade their own pain. Common one, we use a numerical pain score. It's a grade between 0 to 10. So 0 is no pain, 1 is least pain, and it will go up to 10, the worst severe pain. So that is how we grade. And the patient will tell us, what is your number of pain? So if the patient says, my pain is 8/10, that means quite severe. If patient say my pain is about 2 to 3/10, that means it's a very mild and moderate pain. So that's how we grade. We have also other scores, for example, visual analog score, where the patient has some grimacing on the face, how does it present. And in children, we have specific types of pain assessment as well. So this is that we can do to assess your pain. Yeah.
So I think that is very good. At least the patient, you will be able to understand actually this type of patient is actually what type of pain, because generally everyone would just say I have pain, but how pain it is we actually do not know.
Yeah. Because it is important when we have a grading of this pain scale, what the method of pain management we want to offer to the patient. A mild pain is sufficient with the ordinary medication, paracetamol or normal painkiller like COX-2 inhibitor, for example, 𝐭𝐚, for example. So if patient become more severe, we can increase. That is, we call it a pain ladder, WHO pain ladder. So it's a stepwise increase of the pain combination of drugs, so that the patient will have a better pain control with that. Towards the end, when the pain is so severe, the ladder become higher, the third ladder, for example. So we give some opioids, for example, mild opioid, for example, tramadol, or we can give morphine, for example, in cancer patient. But sometimes after that third ladder also, the patient still suffer pain. So what should I do? And then comes the fourth ladder, that is interventional pain. We do blocks. We do some, like I said, radio frequency ablation of the nerve. Sometimes we have to do intervention like discectomy, for example. That's how we do.
Okay. So, doctor, what is your advice to the patient, especially when they are suffering pain, for example, 5 to 6 for almost about 3 weeks, and it really affecting their life? So, should they actually still continue with their normal medication, or should they actually come forward to seek for your advice?
Oh, this type of patient usually is mild to moderate, 5 to 6. Usually what I do, I will examine the patient and I ask some what you call questionnaire. Where is your pain? When your pain actually worse? Any aggravating factor, for example, when you do that, you increase pain. And also what sort of pain actually you have, for example, throbbing or like burning pain, because the pain quality is different. Sometimes we want to identify, is it neuropathic pain, burning usually, and like electric feeling, something like that. Yeah. So that's how we assess. And then after that, I will usually do some tests to the patient to ensure that the pain actually is not from the organic cause. For example, I give you an example. If from the bowels, if the pain on the abdomen, so maybe it because of appendix, or because of pancreatitis, or because of any obstructed bowels. So we try to exclude that pain origin. And there is red flag also. If there is a patient had fever, weight loss, some the signs of cancer, and then it's a red flag. Then we have to be careful, because sometimes pain related cancer pain. That's how we have to, a lot of things that we have to find out and then exclude. After we find certain things that specific, for example, if the pain is related to spine or joints, then we do some investigation. All right. It depends, either normal X-ray, MRI, or CT scan. It depends on the type of pain. So this moderate pain, usually if it is, for example, patient mild backache, for example, I can offer MRI first. Usually this type of patient, they don't have severe changes on the spine. Sometimes because of muscle strain, incipitous muscle, sometimes facet, simple one, sometimes discogenic pain, and the disc sometimes normal. So this type of patient, I don't intervene much. I will give some simple, the current medication we continue. Sometimes we have to adjust here and there, add other types of medication. And then at the same time, I would advise the patient to change the lifestyle. So sometimes the lifestyle actually cause pain. Patient working like heavy lifter, angkat barang, all this, and then do heavy job. So that also cause pain. So we advise them to change and how they lift the things. And then ergonomic also. Ergonomic, if office worker, the way they say and they strain every day in front of the computer. So all this actually have to improve. And then at the same time, we advise physiotherapy. And after that, if it doesn't work, and we give sometime maybe 1 month, 2 months, or 3 months, and then we advise further escalation of therapy, either intervention or further what I would advise interventional pain management.
Dr. Nordin, based on your explanation, it seems that you have to work across different specialty, like because just now you mentioned about cancer pain. Many at times, like patients suffer from a very severe pain, could be origin of cancerous self, right? So perhaps you have to work with oncologists, with orthopedic pain, right? Osteoarthritis. Perhaps you have to work with orthopedics, yeah, and different internal medicine, etc., right?
Yeah, usually pain is a fifth vital sign, and it is no man's land because it can end up to any doctors. Usually the pain is the first sign, the first complaint that the patient see doctor. Pain, they see the GP first, the primary doctor, and from there the GPs either refer to us or refer to any doctors. So if any patient come with pain, usually I have to see what type, like I said just now, what type of pain is it? Is it a somatic pain? Is it a neuropathic pain? Because this actually implies the medication that we want to give to the patient. And then from the multidiscipline management, if the patient is having cancer or I detect a cancer pain, surely I have to get advice from my oncology colleagues to have to have a look and do certain what you call this a proper workout and management of the cancer. And if the pain because of the origin from the bone, for example, if there is fracture, of course I have to ask my orthopedic colleagues to look after the fractures. And if it is just simple musculoskeletal pain, which is very generalized and does not specific for any discipline, for example, then I should be able to manage accordingly with a conservative or interventional according to the severity of pain. We had some patient, for example, fibromyalgia. This is generalized pain, which actually the patient can complain of many things, which is not specific. Of course, there is some criteria to diagnose fibromyalgia. I could not manage on my own for a domain or pain which caused by other origin, which needs special attention from other discipline, like I told you just now.
Okay, very great. So Dr. Nordin, actually as a final, would you have actually any advice to your patient, right, on especially like those having chronic back pain currently? Do they actually continue suffer with their pain, or should they come forward to see you, and what are the things that you can offer to them in terms of interventional procedures?
Yeah, thank you. So actually when the patient has already suffered backache quite some time, weeks or months or years, so when the thing is worsening, they should come to see a specialist, because there actually they had to find out where the pain generator is. And then usually the pain actually is not very pleasant because it keep on coming, and whatever medication is no longer works. Or if this patient become depressed already, or it disturb the work and then the sleeping pattern. So all this actually is time to see a specialist. So like I said just now, if patient has some suffering backache, so if patient has what you call backache for some time, I have to give some exclusion of many origin of pain. It can be many things. I have to pinpoint where the pain generator is, and the patient should explain to me the type of pain, the nature, whether it's throbbing, whether it's burning, or whether it's radiating pain, so I can identify the most likely pain generator. From there I will advise. It depends. Okay, the treatment usually intervention. All right.
Do you mind to share what are the interventional treatment? Like maybe what is the most common interventional treatment you would do, especially for lower back pain?
Yeah, for the lower back pain, I give you an example. If we diagnose, we suspect a facet joint, for example. So I will do radiofrequency ablation to the facet joint innervation of the nerve which innervate the facet joint. We call it medial branch radio frequency, medial branch nerve radio frequency. So we burn the nerve. The nerve that means no longer there, is already burned, so the pain is not passing to the facet joint. So it will reduce pain for at least 6 months to 1 year. It depends on the patient's because the nerve will regrow again later, and it will come back again. It won't be permanently after one procedure that the patient pain free forever. No, it will, because chronic pain it doesn't work that way. The patient has to live with the pain, has to adopt his own lifestyle with the pain, adjusting so that the patient don't suffer much, but we actually, with the help of this block, it reduces pain to the extent that the patient can do normal activity. So therefore, in other words, it's not reduced 100% pain. That means it's not total pain free. Sometimes it get reduced to 80%. It's considered successful. Yes. So the patient must be informed before the procedure that we don't have 100% pain relief. It will be some degree of pain there, but usually it suffices for the patient to be to have a normal life after that.
But I think good to know that with one procedure, at least it can last for 6 months, right? Which is
usually 6 months up to 1 year. It depends on the patient to patient because it's variable according to individuals.
Very good, Dr. Nordin. Do you have any advice for the patient that currently suffering from chronic pain?
Yeah, some tips on the patient with low back pain. So all patients should be instructed regarding a proper posture, for example, on sitting. If office worker, they have pain because of the strain working with the computer. So ergonomically, the patient should change the posture, maybe with support at the back, and they have to change a proper chest, proper height, proper shoes, for example, so that the patient will have some realignment of the back. And at the same time, they have to change the lifestyle. That means if the patient usually do heavy work, they have to reduce the work of lift, how to lift the things. They shouldn't bend, or at the same time, the patient should have a proper sleep posture. They have to either change on the side, sleep on the side with some support at the spine, and avoid too soft mattress. Yeah, and then weight reduction is also some factors which cause burden to the spine. So when patient is obese, of course, the spine have to support heavy load at the both either spine or facet. And then patient have to stay fit and active with the exercise which is comfort and according to the ability of patient with that pain. That means do not overstrain, do a milder exercise instead of heavy duty exercise. Okay, and then the patient should be mobilized early. Do not rest in bed all the time. That means patient has to move around and has to make sure that the musculoskeletal is working and not becomes what do you call this, tight, and also what do you call this, not moving. Yeah, and then at the same time we have to avoid sudden and jerky movement when there is trigger to our like heavy turning or heavy whatever jumping, to avoid strain to the back. And then of course we have to do some stress management so that it reduce stress to the muscles, and this also can be done at the physiotherapy. Okay, we can advise also patient to have some proper physio so that the work on the spine will be less, and then certain types of application to on the spine. Sometimes we had some not to say painkiller, something that reduce and soften the pain sensation at the back. In physio they do TENS, all these things. Yeah, but at home the patient, like I told you just now, they have to change the the way of doing things every day lah. All right.
All right. With that, thank you very much, Dr. Nordin, for joining us today, and we hope to see you in the next episode.
Thank you very much and very much welcome.
That's wrap up today's episode of Makota Ask the Expert channel. A huge thank you to our exceptional doctor for sharing their knowledge, passion and dedication with us. It is truly inspiring to see how their work continues to shape life and elevate the standards of care at Makota Medical Center. To our viewer, thank you very much for tuning in. Don't forget to follow us and share this video to your friends and family. Thank you very much and see you again soon.